Chemotherapy is a very important treatment for many types of cancers, so we use it a lot. Unfortunately, there are often side effects associated with the therapies that we use for the treatment of this particular disease, and cardiotoxicity is one of these toxicities. For example, it could be congestive heart failure, which would be a late finding. It could be inflammation of the heart, which is something like myocarditis or pericarditis. It could actually be an arrhythmia, in which case it could be something like atrial fibrillation. There are many different types of cardiotoxicity. In general, the most serious kind that we think of in terms of treating patients is the cardiomyopathy, which can lead in its most severe forms to congestive heart failure. Several decades ago, I would have said that there were probably just a few drugs that can cause cardiotoxicity. One of the benefits of developing cancer in this particular decade is that we have many more treatments to offer our patients, which is a good thing. But all of these treatments can have toxicities, and in particular, cardiotoxicity can occur with several drugs, not just one. In particular, I would point out that anthracyclines can cause cardiotoxicity, in many cases can lead to cardiomyopathy, congestive heart failure, and actually can have a fatal outcome. So this is a very important cardiotoxicity for us to remember. But recent data has actually shown us that in some cases, this particular type of anthracycline-associated cardiotoxicity can be reversible, which is a good thing for our patients to know. Trastuzumab is another monoclonal antibody therapy that we use frequently in both the adjuvant and metastatic treatment setting for patients with breast cancer. This drug also can cause cardiotoxicity. In this case, this is a drug that often has reversible cardiotoxicity, which is a good thing for our patients. So if they do develop this particular toxic side effect, we know that reversibility can often occur. Cardiotoxicity can occur with patients of all ages, but in particular, one of the risk factors for more significant cases is older age. Younger age is also a risk factor, so patients that are under the age of 4, in particular with anthracyclines, could be at particular risk. Gender is also a risk factor, so female gender is considered a risk factor. Any patients that have comorbidities, so even at the time of deciding to embark on treatment therapy, if they already have some signs or symptoms of cardiac dysfunction, that could predispose them to increased cardiotoxicity. Depending on the agent that we're giving, we can do certain things to try to ameliorate cardiotoxicity. For example, with anthracyclines, which we use a lot, 60,000 patients this year in the United States will be treated with anthracyclines. We want to assess for those risk factors. Occasionally, we can give an analog of that same type of drugs that causes less cardiotoxicity. We want to look at those comorbidities, certainly before we start a treatment therapy with anthracyclines. And there's actually an agent that has been shown to provide cardioprotection in some patients, but we have to be careful about where and when we use that particular drug. We don't want to affect the therapeutic index of the chemotherapy that we're using. Anthracyclines, which have been around for a long time and are still very valuable in our armamentarium of chemotherapy agents, cause damage by actually directly affecting the myocyte or cardiac cell. They actually can injure it and kill it, and that's generally considered irreversible. The targeted therapies, and in particular trastuzumab, which is used for patients with breast cancer, cause reversible, in many cases, cardiotoxicity, so I think that's important. All targeted therapy drugs, although when initially this particular class of drugs was developed, was thought to be less toxic than our standard or traditional chemotherapy, they all do have side effects. So I would say that patients need to be cognizant that cardiotoxicity can occur with some of these targeted therapy agents, and in particular, I'm thinking of trastuzumab, sunitinib, sorafenib, bevacizumab can certainly cause changes in blood pressure. Patients need to be aware of the potential.